What we're going to do now is to move into a phase until about 2 o'clock of further deliberation on the evidence and votes. So to make sure that the system for voting among the CEPAC members is up and running, I'm going to ask Kat to come up and do a test vote question.
All right, the test voting question for today. Admitted in 1870, who was the first woman to graduate from MIT? Please raise your hand if you're having any problem with Turning Point, responseware.com, and we'll come around and help. Do you know that you can see up here when you're done?
Yep.
Okay. Looks like we're still waiting on 3 more votes. 2 more votes. All right, thank you, everyone. The correct answer is A. Good job to those 2 people. Ellen Richards. Okay, I think we're all set.
All right. Were the other women who graduated in 1871, or is it just were they?
I defer to Maggie.
You defer to Maggie on that one. All right. 1870, though. That's anyway. It's a long time ago, but still a long time after MIT started graduating graduates, I'm sure. All right. So that's good to set this up. So let's move into this phase. So just again to set the context, what we're going to do is do a super brief review again of the evidence and ICER's rationale for its preliminary ratings of the evidence, and then we're going to open it back up again for deliberation among the CEPAC, the patient experts, clinical experts, and we have the ICER leads on the research team up here to debate that. And I'll try to keep the discussion and the votes going so that we can be done again by 2, because the goal is to have a short break followed by the policy roundtable. There is always an instinct to want to move into applications of the evidence as we start to do this phase of it, but just to remind you that we will have a very rich opportunity to delve into things about future research, pricing, coverage, and other aspects after the break. All right, so for the first question, the vote will be cited this way. For patients with DMD, is the evidence adequate to demonstrate that the net health benefit of deflazacort is superior to that provided by prednisone? David, would you like to very briefly summarize again and point out to the CEPAC where the evidence is in their evidence summary, and then we'll have some debate.
Yeah, if you go to pages 3 and 4 of the evidence summary, you've got table 2 showing the trials and the observational studies. You have table 3 and 4 looking at harms. I think overall, there's very little reason to think that deflazacort is less beneficial than prednisone on efficacy outcomes. I'm not very convinced that it's more beneficial on efficacy outcomes. I think I have a lot of concerns about confounding, but it might be. I think the evidence is quite convincing, is reasonably convincing that there is less weight gain. I think it would be unlikely that that's not true, and weight gain seems to be an extremely important outcome. And so for that reason, we said that and there's this swirl of other possible side effects out there, including reduced growth, some concern about fractures. So there's a little bit of uncertainty in the background. So given all that, we felt that deflazacort was at least comparable and might be better than prednisone.
Okay. Let me just invite a quick comment, if there are any, among the clinical experts, again, seeing the voting question and the evidence, which I know you know as well. Are there any perspectives about how you view its interpretation that you think would be important to highlight again for the CEPAC?
Maybe just a quick comment. I don't know if everyone is aware that the field thought that there was enough equipoise about this exact question, that there is in fact a long longitudinal study, the 4 DMD studies, a national study that is looking exactly at this question, long-term benefit versus efficacy. There are 3 arms in that study, so the results hopefully will be available in the next year or so.
Okay. Now, sometimes this is obviously a question that applies to coverage as well, but is there anything about the evidence that you think is important to highlight for which there's a patient coming in to begin treatment with prednisone or deflazacort, and based on the evidence, you know that it would have superior efficacy for this patient because of their clinical profile of some description? Or, as you said, is there clinical equilibrium and hard to tell?
Well, I think that is absolutely true. As clinicians, is that individual patient based on everything we know, and the information might not be perfect, but based on everything we know for that particular individual, we try to make the best choice, together with the family, what is most important to them in terms of side effects. If you have a family that that obesity is running very high in the whole family, probably, as a clinician, you say, okay, maybe the evidence is good enough that I will really to try the deflazacort first. So yeah, absolutely. There is a clinical judgment that is very nuanced and is very individual based.
Okay. Oh, go ahead, Peter.
So, when I start a child with DMD on steroids, I really regard it as a collaborative process with the family. And usually it takes multiple visits before we start, and I begin the discussion as early as possible because it is a big decision and there are a lot of side effects. And I typically review the side effect profiles that are known about both, and based on individual preferences, concerns about certain side effects, I like to come to a decision working jointly with the families.
Okay. I probably just violated my own guidance of slipping into discussion that should be in the policy roundtable. It happens to the best of us, or the worst of us. So, questions from the CEPAC? Jason. Oh, by the way, you guys, you can use your tent cards if you want to signify if you want, or you don't have to raise your hand. Either way. Jason?
As I think multiple members of the CEPAC have articulated, there's some concerns about a number of methodological issues in this setting, but both methodological concerns with the 3 randomized controlled trials, but also concerns about unmeasured and measured confounding in observational data. But I guess I heard a little bit, I felt like I heard before that, so one thing that can reassure us against confounding explaining a difference is the magnitude of the effect. So 3 years of difference, I mean, does that give you any insight? That seems pretty big to me. So does that give you insight as to whether, no, that could be partially due to unmeasured confounding, but does that give you insight as to whether does that give you some more confidence that the deflazacort is superior clinically?
It's hard for me to say because the responses, both in terms of efficacy and side effects, vary so much from patient to patient that it's hard from my personal experience to generalize very much. And what I know of the literature, there seems not to be a consensus about that question in particular.
David, any other comments about that?
I have to say the magnitude didn't seem big enough to me to necessarily overcome the concern, but in part of that I'm being influenced by the randomized trial, honestly. So the RCT data have me less convinced about it.
Yeah, that's helpful.
Okay. I'm sorry. Yes, please.
I just want to add one thing from the patient's perspective. So I think one thing that hasn't been really summarized and accounted for that's significantly important to patients is the degree of cushingoid appearance from both treatments. When you're dealing with teenage boys, that's a big deal. And I haven't seen reference to that in the model or in the data. And then the behavioral aspects as well. If you obviously have a child that's on glucocorticoids from a very young age, the degree of behavioral disruption that causes is really impactful to families. So I understand focusing the review on the degree of efficacy for both treatments, but the side effect profile is is extremely impactful to families.
David, you might want to just comment on that again. I know Cushingoid
Yeah.
was in the model, but I'm...
Cushingoid,
So go ahead.
Cushingoid was included in the model, but there is evidence that deflazacort is better on Cushingoid appearance.
How much, can you remind the panel?
Well, I had a question about that too. Was it a Cushingoid yes, no, or was it a degree of Cushingoid appearance?
In the model, it's yes, no, I believe.
Exactly.
Yeah, it would depend on it was Howard McDonald defined it, and.
Sorry, you might have to pull that a little closer
Sorry.
to yourself.
Yeah, we used Cushingoid and we used Wake, and we used them independently, even though they're likely very highly correlated, but we used those absolute differences in both.
I hate to keep coming back to that, but this importance of degree of Cushingoid is extremely important to patients. I mean, if you're extremely Cushingoid, that's much more difficult for the boys to deal with than if you have a slight Cushingoid appearance. So if you're reducing it down to a yes, no, then you're missing that nuance.
So in terms of the way it got modeled, the McDonald numbers were 6% on deflazacort with Cushingoid and 9% on prednisone. So an additional 50%.
But an absolute difference between 6 to 9.
Yeah. Yeah.
I'm shocked at how low those numbers are.
Yeah, I mean, it's funny. I mean, that's from the McDonald study, which tended to have higher rates than a lot of the other things. And then behavior change was 3% deflazacort, 6% prednisone, so a doubling on the behavior change. But again, I don't think we really know these things incredibly well. Both because of the specific way we're looking at the outcomes, and just because of the trial designs. The randomized trials are short, the observational studies are long. Mm-hmm. It's just hard to know what to do with that. I was interested actually, and I had mentioned this in my presentation, what you all thought of the growth delay. It seems clear that that you're more likely to have growth delay on deflazacort. And I was thinking in terms of what was important to teenage boys versus what might be important to the parents, how that played out.
So I will say that I think there's a huge confound in that data, and that's that the clinics that tend to put boys on deflazacort are the ones that tend to start them earlier, and that there are a lot of patients that are on prednisone who may have started at a clinic that may not be as aggressive in terms of when to start boys on treatment. So I think that should be examined in that calculation for sure. In terms of growth delay, that's of extreme importance to the boys. I have a 16-year-old that I can actually ask that question of at this point. And he's on his feet at 16, and so I can ask him, and he's very concerned about his height. He has a crush on a girl. But we've had that conversation. If you came off steroids, but that took you off your feet, would you do it? And his answer is no.
Just related to that, I would add that, there are two sides to the steroid question to answer your question, or two sides to the answer to your question. There's a social side, which Mindy just gave reference to, and, that's what this disease is all about. How do you look and feel as a person going through this? But then there's also this clinical black and white side that we all like to focus on, which is the hardcore medical side of it. And just of note, there could be a positive, if I can even use that word in this conversation, to being shorter in stature, and that is that it does keep you lower to the ground. Your center, if you will, could actually help prevent some falls. I'm stretching it a bit, but there is a benefit at times to being on the shorter stature if you are someone facing this disease.
Okay, all right, we're trying to be brief because we have miles to go.
So quickly, the answer to the question whether there's a difference between patient and parent, there is. The individuals do hyper-focus on height, just out of what they're thinking, and families do look at the more practical aspects. So there is going to be difference, and as Dawn has alluded to, some of them can be actually a positive.
All right, thank you. All right, why don't we go ahead and vote on this one then? I will let you know when we have the full 17 responses, and we'll show the results. Okay, we got to 16 very quick. There we go. Thank you. Okay, 10 yes and 7 no. so some split. Why don't we try to have a very brief debrief, just so we can capture it for the record. Somebody who voted yes, could you express, I mean, you've heard some of the rationale up here, obviously, I think they could support that. Your vote was determined mainly by what factors? Steve?
I was a yes, and in that statement, the term adequate was relevant to me. So the evidence is maybe adequate, but not good.
So you voted yes or no?
I voted yes.
You voted yes, because it is adequate, but,
So there's-
now I understand, sorry.
Great, thanks.
Okay, it's not great evidence, but it's adequate.
Yeah.
Could you just say one more word? Why was it adequate? What was it that tipped you into
Well,
a
I
yes?
think the observational studies are, not ideal, but it seemed like that's where the data were most compelling.
Okay. And someone who voted no, care to state how they looked at the evidence? Jean? Can you please make sure you push your button there?
Sorry, the word I focused on was superior. I did not find that the evidence was adequate to indicate that it was superior, comparable perhaps, and I would reiterate or iterate for the first time, I would like patients and their caregivers and providers to have the option to use either, but I didn't see that it was superior.
Okay. Thank you. Let's move to the next voting question, which is going to shift to the clinical effectiveness of eteplirsen. The question is, for patients with DMD amenable to exon 51 skipping drugs, is the evidence adequate to demonstrate that the net health benefit of eteplirsen added to corticosteroids and supportive care is superior to that provided by corticosteroids and supportive care alone? David?
So you've got on page 5 a table looking at the clinical benefits and I think of eteplirsen, and I think you can essentially assume that there's no reason to particularly be concerned about harm. The randomized trial showed higher dystrophin levels, so that there were concerns about that, but then the subsequent FDA required open label study clearly showed that you do get boosts in dystrophin levels, admittedly to what seemed like fairly small numbers. The randomized trial for motor function was inadequate and sort of all over the place. We have historical data suggesting that there may be benefits compared with historical controls, but that has the usual problems of small benefits against historical controls in a disease that's heterogeneous. We felt that the data were insufficient.
Dave, can you make a quick comment in terms of the historical controls? Are there concerns that the exon 51 skipping population or subpopulation, is it being compared to that same subpopulation in historical controls, or is there some blurring at the edges that lends more uncertainty to that comparison?
So some of the studies absolutely were comparing to other patients who were amenable to exon 51 skipping, but even within that, that's not a homogeneous group.
Got it. Okay, so this is another kind of core question. Adequate evidence for eteplirsen versus best supportive care, basically, with corticosteroids. Questions from the CEPAC? We had a good debate or discussion this morning, but anything else you want to put on the table? If not, while you're thinking, again, a further opportunity for either the patient representatives or the clinical experts. Again, we have talked about some of these issues, but feel free to hit the nail on the head again if you wish.
Yeah, I mean, again, I feel like this is an uncomfortable position to be in, as someone whose son has been on eteplirsen, because the net health benefit, if I'm being asked to comment on the pricing structure, that's an uncomfortable place to be as a parent. But just in terms of the efficacy, I think there are two ways to take a look at this. You can look at a short-term bump in function, or you can watch patients over a very extended period of time. And those are the only two ways that you're going to come up with anything definitive. And we have done neither in this disease for this treatment.
Okay.
Yeah, I just want to comment on that because
sure,
there's been some discussions, around, we didn't say this drug doesn't work. We said that we thought the evidence was insufficient. And if it doesn't work, we're giving lots of kids these infusions weekly at an enormous sum of money. If it does work, and we haven't shown it, there are kids all around the world where it hasn't been approved, and in the US where insurance is blocking people getting it. We're in just this terrible state because we don't have better evidence.
Well, I would just add to that, I agree with that, but I think that there are expert clinicians, like these two sitting at the end of the table here, who are in the midst of making that assessment. And they're able to do so because there are patients who do have access. And if that process is interrupted because that access is interrupted, then we will have nothing at the end of it. And so, none of us want, children to be able to access treatment, to have access to treatments that are ineffective. But that assessment is currently being done by, the expert clinicians in our community. And like I mentioned, I think the treatment effect is nuanced enough that it will take time to understand the overall net benefit for these patients. And if that process that these experts are undertaking while they're assessing and treating our children is interrupted, then we will be back to square one.
All right, so as I said to myself before, we're going to get to that in the policy roundtable. That is front and center in the policy roundtable, because and again, obviously we have no statutory power. We have no power to have things taken away. And often health plans do cover things for which they or others think that there's inadequate evidence. So we are going to be talking about the connection between those kinds of judgments and how it should get translated into coverage and pricing in the policy roundtable. Yes, Ed.
We talked about how it's been 3 years and we really haven't seen any additional data, and typically we do see something encouraging or discouraging in that amount of time. Why do we think we haven't seen the data? Is it because there isn't anything there and it's being held back, or are there other reasons why we're not learning more by now?
I'll accept it, because we were going to talk about that at the policy roundtable, but it might be germane. Either Dr. Schiaffaloni or Kang, do you want to talk about your knowledge of the ongoing trial and when the data are expected or could have been? I have a comment maybe after that, but go ahead.
So I don't know. I think that the phase 3 study, hopefully the results will be out soon. But I think that the missed opportunity here is, for example, now there have been patients who have been received the drug not for 48 weeks, but maybe for 4 years. So what will their muscle biopsy look at 4 years rather than 48 weeks? There is some maybe knowledge that maybe it's more about time of exposure rather than dose, and that maybe, yes, 1% at 48 weeks, but do we know what happens at 4 or 5 years of exposure, for example? Could we reach maybe 3% or whatever? And then, the other unmet opportunity in part of having maybe stronger, better longitudinal, observational, open study, registry, and so forth, coordinated to really give us even real clinical world longitudinal data. Remember, patients are very smart in family, and in many other diseases, we all know that patients come off medications, especially if they require an IV infusion every week or a lumbar puncture 3 times a year, or, having a poten. Patient will just quit and say, this is not worth it. So we look, for example, at that data, how many patients they want to discontinue drugs. So those are all real life experience that will be nice. Again, not maybe perfect, but very important information.
Okay, sure. Dawn.
One quick comment. So for me, I share Mindy's kind of confusion, if you will, or concern about the patient voice here kind of stuck in the middle. But as it comes to adequate evidence, our end goal here is to produce dystrophin, right? So these kids are not making dystrophin. And if our end goal in this, I'll remind the audience, it's first generation medicine that we're talking about. It's getting off the ground with the first step here. And if our goal is to make dystrophin, there is evidence. You can argue about the amount and the benefit behind it, but there is evidence that dystrophin is being produced in these kids. And that's really, hard for any of us in the room to detect the benefit, and that's really not what we're here for. But the evidence is there that this exon eteplirsen is producing dystrophin in these kids.
Yeah, I know the FDA obviously will try not to relitigate the whole thing, but that was part of their internal debate. Their terms is reasonably likely, I think, for the surrogate outcome to lead to a health outcome. Our language is, again, adequate evidence that it creates a net health benefit. So it incorporates that issue that you raised, which is if we acknowledge that it does raise dystrophin, the next step is, does it connect to a net health benefit? And is the evidence adequate to support that? Mindy?
Just in
Yes.
answer to that question, I don't know the answer to that question, but it's been a source of immense frustration to those of us in the community. I think there are a lot of us that are out there as parents and clinicians that are making those individual judgments. My son lost the ability to get off the floor at a certain time point, so I started watching from the point that he lost the ability to get off the floor, how long he was going to stay on his feet. Because there is good natural history data that reflects that a patient that loses the ability to get off the floor will lose the ability to ambulate between 1 and 2 years. So I was watching that myself. Is he going to get past that 2-year mark after the point that he lost the ability to get off the floor and still be on his feet, which he was? It would be immensely valuable if that type of data had been collected across the community so that we could have a collective view of it. And it's been a source of immense frustration to me that that has not been done.
Okay, thank you. Any other questions about the evidence from the CEPAC? Okay, please go ahead and vote. Two more? One more, there we go. All right. So 16 no and 1 yes. And sometimes I take the prerogative of not putting the one person on the spot. If they would like to talk about their vote for yes as opposed to no, they are welcome to. But
it was me.
Go ahead, Martha.
And I violated some of my own rules, in part because I think that subjective evidence of patients is sometimes more predictive of what's going on with people than what clinical parameters are tested. And I was very persuaded, I have to say, by some of the anecdotal pieces. And together with the, increase fourfold in dystrophin, I know that's a tiny amount, but still it seemed like it was heading up, and I thought I would go for it. I figured I would be pretty lonely here.
All right. Let's go ahead then. The next question is going to be about golodirsen, the same framing of the question. So David, again, if you can just highlight what evidence is available, and we may not have too much more to add to the conversation, but we'll see if we do.
Yeah, so on page 6 is where we talk about golodirsen. We don't have a randomized trial of golodirsen. What we do have is the change in dystrophin levels over 25 patients. And you can see that the average change in dystrophin levels looks like it's probably a little bit more with golodirsen in that set of patients than was seen in eteplirsen in the patients who were amenable to exon 51 skipping. We have no idea how that relates to function.
Can I ask you a quick question? Why didn't they was there a reason they didn't do a randomized trial between 2 doses, or was that already somehow baked into their thinking? Because you could always learn something by randomizing different doses, even if you don't feel it's ethical to do a placebo control. Do you happen to know anything, or others at the table, about why that wasn't done? Anybody? If you don't, that's fine.
I'm not involved in the study, but the cohort is for this study also looks to be exceedingly small, so that was probably part of it.
Okay. All right. Any questions from the CEPAC? I didn't think we'd probably have a whole lot new around that. Okay. Why don't we go ahead and vote, please? Okay. Martha, we flipped your vote. Okay. Let's turn to what we call potential other benefits. Oh, I'm sorry, what is? Yes, potential other benefits, good, and contextual considerations. On our way towards a long-term for value vote. So here we're going to pivot again from the data that we hope and should be in some ways in the clinical evidence base and talk about things that may or may not be, but which could still represent important potential other benefits or disadvantages of different treatment options. So the question is framed, is it likely that treatment with deflazacort offers one or more of the following potential other benefits that are not adequately captured already in the base case cost-effectiveness model, and we're asked to select all that apply. And the three things that we're going to ask about as far as potentials are reducing important health disparities, reducing caregiver or family burden, or other important benefits or disadvantages. So the purpose of this discussion is to hear comments about A and B in terms of, whether there is evidence or isn't evidence, whether there's reason to think that it's likely that there's an important other potential benefit, and to introduce specific other important benefits or disadvantages that we will either kind of accept in consensus or we will have a specific vote on. So, start with questions or comments from the council. Obviously, we will turn to the patient experts for comments on these for sure. Rob.
So, Steve, just to go back to the base case cost-effectiveness model, we did include caregiver burden and the utilities associated with that in that model. So the question's asking us to say not whether it will significantly reduce caregiver or broader family burden, but whether that was not adequately captured in the base case model, correct?
Actually, in this case, I think it's helpful to interpret that as, given what you've seen in the modeling that tried to capture it, is it significant? And you can either say it is as measured, or you can say, I think they tried to measure it, but they didn't capture it effectively, and it's even bigger than what they said it was. Or you can say that it doesn't seem to significantly reduce caregiver or family burden. And remember, we're talking about deflazacort in the model, and we are talking about it not versus prednisone, but it by itself versus nothing. Okay. Yes. Yes.
Question for Suri. Can you remind us how weight gain worked in the model with respect to deflazacort?
So weight gain was included as a serious adverse event. We also looked at information on time to loss of ambulation. To the extent that weight gain impacts time to loss of ambulation, it's in that loss of ambulation data. But we also separately gave it a disutility, and we also gave cushion-goid appearance a disutility, and this was a 0-1 measure. So that's how it was in there. And I can say that in the base case model, caregiver utility was not included, but in the modified societal perspective of the base case model, the costs that went to caregivers were included in that model.
Sorry, I have to jump in because I made an important mistake. And it's just because we had to shorten the language as it got translated to a slide. And the second I said it, I started to say, that doesn't sound right. This actually should be, it's more valuable for decision making if we talk about its potential other benefits versus prednisone. Because in a way, obviously, prednisone has been the standard of care, if you will, in the US. If you want to argue about the deflazacort being brought in from overseas. But the real question is to talk about whether there are potential other benefits of deflazacort compared to prednisone. My apologies.
I just wanted to ask that question. So weight gain was included in the model as a yes/no SAE?
Yeah.
Okay. So what was the degree of weight gain that was? I'm trying to remember what that was.
So weight gain was as defined in the McDonald study. Where are those rates?
We went through this a lot. I'm not sure. It was around 20 or 25% undesired. So because, of course, these are boys who are growing, and we had a lot of trouble figuring
They're
out
actually
how to define.
not boys who are growing because they're on glucocorticoids. So
Previously boys who were growing, but we were having trouble doing this, and there was a definition in McDonald, and we ended up going with their definition.
We use the numbers from McDonald again because that's where we took the treatment effect numbers. There are pretty good variance in these numbers across studies, different patient populations, et cetera. So the number in the McDonald study was 14% for prednisone and 5% for deflazacort.
Does that have face validity to you? Does it make sense?
it makes sense, but I mean, I kind of keep coming back to the same point. So if you're assessing this based on a yes/no threshold, you know, I can imagine that there are patients that are on either side of that threshold that, you know, I would love to see that kind of nuance incorporated.
I have a question for,
yes, Martha,
for the clinicians.
Yes.
In terms of access to care, you know, when people were importing from overseas, did you see a difference between some families who could afford to pay money out of pocket in terms of how decisions were made for their children? Or did you find that everybody was able to come up with the $1,000 or so that was needed to cover the cost of the drug?
This is kind of a gestalt. Of course, I don't know the numbers, but generally speaking, I think that I would say that probably a large portion of patients that wanted the deflazacort made a decision with their provider that were able to obtain it, but there were definitely exceptions in the lowest social demographic where even the cost was absolutely prohibitive. So unfortunately, I don't know the proportion or the exact number, so this is kind of a gut feeling. Again, a very important, that would be nice data to have, right? And
Stephen,
now we have different challenges for access.
Right, and it also obviously, depending, and this is the policy discussion, on kind of what the prices is and what the coverage is, it will, I mean, I'm trying to think about important health disparities.
Can I make a quick comment related to the weight gain? I was intrigued by, there is a slides where you had the cost of like cataract surgery, fractures, and then for weight gain, there was a cost of $75, which struck me as very interesting. And probably that was based, okay, you have weight gain, you talk to your doctor once about it, and that's a follow-up visit, $75, but you know, the consequences of weight gain in Duchenne, but let alone in everyone in this society, it will be very hard-pressed to say that that's a $75 cost.
So weight gain, there really is no literature on costs of weight gain in a young patient population, and almost all of the sort of downstream cost effects of weight gain happen in older patients because of diabetes and associated health. Those patterns just aren't in kids. So to the extent, again, that weight gain makes you lose ambulation, that's in the model because we have time to loss of ambulation. For an added cost of weight gain, we used a physician office visit. And there just is no literature on that, and I wish it was better measured and so forth, and I'm sensitive to that, but that's all we had.
And then just a comment that probably the parents want to weigh in is that if you and I weigh gain and then we say, okay, you have diabetes, we want to lose weight, we can do something about it. And, you know, some succeed, some don't. If you have Duchenne and you're in a wheelchair and you gain 20 pounds, those 20 pounds are never going to come off.
Mm-hmm. I think that there's some caregiver burden that we're certainly not capturing there, that it's harder to have a heavier child, especially if they're non-ambulatory. So, but we don't have a measure for that.
But that's what I was going to comment on. I mean, a family with Duchenne is kind of a microcosm between caregivers and child. And so if the child has gained weight, you know, then that's significantly more difficult to transfer them, to move them, and then there's incurred costs. Like if you can't lift your child, then you purchase a Hoyer. If you can't lift your child and it's difficult to lift your child, then you've got back injuries. I mean, there's impact to the caregiver and cost to the caregiver as an impact of the child's weight gain. At some point, I would love to see kind of that incorporated into the model. I mean, even if a child maintains the ability to turn themselves over at night, then the parents aren't woken up and they don't incur the, detrimental health costs of not ever getting a full night's sleep, and those consequences are well understood, I think. So I would love to see that microcosm incorporated into the pricing models.
I would just say we're a long way from that in terms of the data that's collected. And I just want to point out that in the model, we also did assign a disutility of 0.05 every year for the weight gain, in addition to the costs. And then we did that again separately for the Cushingoid adverse event. But there's a lot more room for better data collection in this patient population, for sure.
Okay, good. Sorry. It seems like we should probably go ahead and vote on this set of potential other benefits, as we've got others to come as well. So please go ahead and remember, I'm sorry, were there any other important benefits or disadvantages at this point? I guess we talked about weight gain. Trying to think if we should vote on that one separately. This is the question we always face, whether we should just kind of accede to it and mention it, or whether we should take a separate vote on it. Why don't, since it's really the only separate one that has come up in a concrete fashion, why don't we go ahead and consider that to be C? So a potential other benefit of deflazacort would be less weight gain.
Stephen,
But wait, that's in the model, but I guess the question is whether it's adequately captured in a way that decision makers trying to value deflazacort should think of it.
I'm struggling with A because I feel like we could have either an increase or a decrease in disparity depending on someone's situation. I think Martha was trying to get at as was Emma. If you couldn't possibly get it and now you're insured and you can get it, that's great. But people who used to be able to afford it may now have additional barriers that make it unaffordable. So how can I vote on that?
So the easiest way to vote on this is because it's meant primarily to capture benefits that are missing from the model. It does sometimes pick up disadvantages, but the primary goal of that question is to pick up something that has a particularly valuable impact on reducing disparities. So if you do not feel that you have adequate confidence that that would happen with the introduction of deflazacort, that's the way I would vote.
But isn't that always about financial accessibility unless there's some, particular genetic piece to
Now,
it?
sometimes we find that there are, for instance, treatments that can be administered in rural populations, whereas the other ones can only be administered in an academic medical center. That's definitely, many people think that would help reduce disparities because it can be more accessible to vulnerable populations. So that doesn't have to do with the insurance system. There are other things that could involve the insurance system.
So this is not about socioeconomic and equity issues? This.
Yes.
Yeah, I was reading that as disparities as opposed to access. So I think access may have stayed the same, but I'm reading it as because particular Medicaid would have been wholly restrictive on a import. I think I'm reading that as disparities being a vulnerable population by income, but.
But what we do is we capture some of the discussion around these points and put them in the report as well. And I'll just signal for the CEPAC, they know, and for the crowd, ICER is going through a value assessment framework update this year. And you might be not surprised if this question were part of our thinking about how to improve our public discourse, because the concepts are important, but how we tease it out and frame it for votes, I think, can always be looked at and improved. But we've tried to capture this, and I hope now the framing is at least helpful too. Jason? Maybe
Steve,
not.
I'm really sorry to bring this up because I do know that this makes the proposed voting, if you want to make C the weight gain, I know this would make it more complicated, but I submit, and feel free to shoot me down on this, my colleagues, but I think I was going to vote yes for C, not directly addressing the weight gain, but I think that it's important to remember that in decision analytic models, we're using our estimates of average treatment effect, and that in something with immunomodulatory agents, heterogeneity of presentation, we're likely to have substantial heterogeneous treatment effects that are masked by those analyses, and therefore we don't maybe understand those things, but it's better for clinicians to have more options, and that is another important benefit. So I was going to go vote for C on that basis. So if we're going to convert C into the weight loss thing specifically, if others don't think this is important, I can take this aside and.
Let's take that latter piece that was part of the policy roundtable
Okay.
and how we addressed it there. I think it's
Okay,
conceptually it's better than putting it in here.
Got it, thank you.
Okay, so C is going to be weight gain. A reduced weight gain is a potential other important benefit. Okay, let's go ahead.
I'm sorry, you've thrown me off though, because I think my primary mechanism by which caregiver family burden was reduced was the reduction in weight gain, and therefore I used to know how I was going to vote on B, and now I don't.
Well, we can almost have it both ways, because again, the purpose here is to be comprehensive, but hopefully to be clear. So either we leave weight gain out and everybody factors that in as part of reducing caregiver family burden, or if we want to call it out as a separate kind of specific clinical other benefit that has maybe more relevance than some of the other aspects that might not fully be captured in the model, we could do it that way.
So if weight gain is C, is there another mechanism by which B that
I would say you could vote
family-
for both B and C if you were thinking about weight gain for both. Because it's both, I mean, I understand it's a mechanism to reduce caregiver burden, but there might be, even if it doesn't reduce caregiver burden, there might be other reasons that we might value less weight gain for the kids. All right, thank you. I know you guys are thinking hard about this, I can tell, thanks. So go ahead and remember A, B, and or C. And because the voting mechanism here doesn't let me know when you're all done, I just have to kind of look and see when you look up at me to know that you're finished. And then I almost always have to ask anyway. Is anybody still voting? Okay, here are the results. We have 17 voters. All right, we have 1 out of 17 saying it will reduce important health disparities, 12 will reduce caregiver and family burden, and 14, since we relabeled C, as the weight gain. Okay, I'm going to move on from that and not have a further debrief of the votes. The contextual considerations for deflazacort, and we'll get to eteplirsen and golodirsen in a second for the same series of votes, are the following. First, the question is, are any of the following contextual considerations important in assessing deflazacort's long-term value for money? Select all that apply. And again, you are one body of independent people thinking about this. Decision makers will have their own way of weighing and thinking about contextual considerations. But again, it's a chance for us to raise issues and to send some signal about how the CEPAC at least thought through some of these. So what we are looking to talk about is deflazacort intended to be for the care of individuals with a condition of high severity? Is it for care of individuals with a condition that represents a high lifetime burden of illness? Is there significant uncertainty about the long-term risk of serious side effects? Significant uncertainty about the magnitude or durability of the long-term benefits, or additional contextual considerations? All right. Now, a lot of words of judgment here. Significant, high lifetime burden of illness, right? There's no clear dividing line of yes or no, it is or isn't. That's why it's partly a discussion. Can I invite any of the patient representatives? Because I know, again, you all live with this, and some of these words may or may not even connect with the way that you think of the condition and your family's experience with it. But do you have any comments that you'd like to share with the CEPAC as they think through their votes on these?
I think the benefit is pretty unequivocal of the use of glucocorticoids in Duchenne. So for my family, the side effect profile has been the most important discussion that we've had. And so I think that would probably fall under C, I guess. But the magnitude of the side effect profile between the two treatments and between no treatment at all has been the most important discussion that we've had as a family.
David?
I was just going to say, this isn't really meant to be versus for this one. It's not versus prednisone. It's more about the condition and our understanding of drug. Often we're not talking about a drug that's existed since 1965. Often it's more like golodirsen, where we have a lot of uncertainties. Here, we do actually still have some of these uncertainties, but, you know, this drug has been around for 50 plus years.
I mean, I think the data that, with this, you know, there was a concern raised about the data in terms of long-term benefits. I mean, I feel like the understanding in the community is that that's pretty unequivocal. If you can delay loss of ambulation, you can delay need for, you know, respiratory support, which, you know, has a whole host of benefits as well. So I don't consider that equivocal at all, but.
Can I ask maybe the experts on that as well? The place we were unsure of that on was once people were late non-ambulatory, whether steroids continued to be of benefit. We had at least seen some discussions that some providers thought you should stop steroids in that setting and others thought you should continue it. So that was an uncertainty.
Actually, I really do want to hold that for the roundtable because it's directly related to the coverage issues and to clinical decision making. Any thoughts or questions from the CEPAC panel as they look at these questions and want to ask questions about it? Stephen?
Sir, can you remind us how you handled the cost of deflazacort over the long term in the model?
I'm not sure exactly what you mean. The model's lifetime. Deflazacort has an annual cost in the model, and it's always that same cost. Yeah. We had a 37%, if memory serves, of patients discontinue the drug upon becoming non-ambulatory because that was what we had available to us in the data. So there's some controversy about that, whether you should keep taking it or not. We just had 37% discontinue. But other than that, you got the full cost of that drug every year you want it.
Okay, I'm sensing a move towards voting. Why don't we go ahead and do that? So again, this is all that apply. And since we didn't come up with a specific E, just don't vote for E. Unless you did have one, a pocket contextual consideration that you wanted to throw in there, but I hope I gave you the chance to do that. So again, I'll look to you all after you're done voting, look up at me, and we'll take it from that point. Okay, looks like we're all done. Okay. All right, out of 17, 15 care of individuals with condition of high severity, 16 individuals with a high lifetime burden of illness, and you can see the rest, 2, 5, 2. Does anybody want to say if there was an additional contextual issue? It could have been just a slip of the finger, but if there was, please feel free to at least raise it now if we have a second or two. Jean.
You're going to say this is for the policy roundtable, but it was the price.
And that was mine as well, same as my comment. Over the next 5, 10, 15, 20 years, perhaps there'll be competition, generic entrant, that sort of thing that would reduce the cost of the drug and affect the ICER accordingly.
Okay. All right, good. So we're going to shift now to the potential other benefits of eteplirsen and golodirsen. It's a judgment call to lump them in together. They're both exon skipping drugs. We know the evidence base is different for them. Your votes on that evidence base, however, have been very, very similar, if you will. So I think keeping them together still makes sense. So the question again, we've done this already, but this is it likely that treatment with eteplirsen or golodirsen offers one or more of the following potential other benefits that are not adequately captured in the base case cost effectiveness model? And this is intended to be compared to treatment with corticosteroids and best supportive care. All right, so reduce important health disparities, reduce caregiver family burden, significant impact on improving return to work or overall productivity, or other important benefits or disadvantages. And yes, C, if there's a question, we've talked about this before, but the productivity can be that of the patient, obviously, or it can be that of the family member. And yes, that means we're double counting. If we say that there's a reduction in caregiver burden that allows them to go back to work, yes, the answer is vote for both. Yes, Lefterius.
I would like to submit something for D.
Okay.
It's that there might be a subpopulation that is...
Wait, I'm sorry, if you push
I'm sorry, yes.
And don't look at me, by the way. Make sure you look. These things are very directional, I think, so make sure you stare at those things when
I
you're
won't
talking.
look at you still. Ever again. So I think that there might be a subpopulation of patients that can really benefit from this treatment. And wider use, more data could help identify better this subpopulation. And I would like to hear if the clinical experts have any thoughts about this.
Wait, let me give you, is the elevator pitch on this? The other benefit is that there are subpopulations with higher benefit that we...
The subpopulation that can benefit more. So the cost of the medication is problematic, especially if, using a number, 70% of the individuals don't really benefit, but there is a 30% of the individuals that really do benefit from this. So if you give it to this subpopulation that can really benefit from this drug, then you have a better chance of becoming cost-effective or close to it. But do the clinical experts feel that there might be such a subpopulation or not?
Please go ahead.
I think there's definitely a possibility that there are subpopulations that benefit more than others, and so far I don't think we've discovered the tools to identify those patients yet.
See, my only problem in a bit with the question is that that's true of any treatment. Any treatment has subpopulations which react with greater benefit or harm. We don't always know who they are, but sometimes we do. So I'm trying to make sure I understand what's the potential other benefit that you think. Do you think that is true for many treatments? You just want to make sure that we capture it for these?
Most treatments don't have the cost effectiveness challenges that we face here. Most treatments provide some degree of benefit. Diabetes medications can help some individuals more than others, but they all get a benefit. HIV medications help some people more than others. We don't know who's going to go to advance to diabetes complications or HIV complications faster than the others, but they all get a benefit from it. The problem here is that it looks from the diverse nature of this disease, it feels that there might be a bigger divide between those that really do benefit and those that do not. And that is the feeling that I have from the different case presentations that we had from families, and that is all that we have to go with. It's a rare disease, and it's really fragmented and everything else. So my feeling is that this could be a subpopulation that really might benefit from this, that will, studies and clinical knowledge will identify in the future.
Okay. I don't think I'm going to try to summarize that too succinctly, because the second time you went through it, I think everybody got a sense of what you meant. And if not, feel free to specify it further or ask further questions. Rob?
Yeah, Steve, could you just comment on how our previous vote around net health benefit should inform this? The phrasing the question is it likely that treatment with this? Now, we found the evidence insufficient to see a net health benefit. So much of what is included in this is basically requires some sort of net health benefit.
Right. So again, we're in a bit of uncharted territory, because as I mentioned earlier, I'm actually not sure we've ever said that a drug has insufficient evidence that it works against best supportive care. I think at worst we've said promising but inconclusive. So logically, however, these were meant to capture further benefits of an effective drug. So if the drug, in your view, is not effective or not shown to be effective, or not adequate evidence to demonstrate it, then it logically should not have other benefits that are likely. They could still be potential, but it wouldn't be likely that they would have these other benefits if they're not, in a sense, their primary benefit is not there. So that would be my guidance for how to interpret this question in light of your first vote. Yep, Claudia.
In that regard, I think the way I may interpret that question is an aspect of that has been brought up by our panel, that there do seem to be patients who have benefited from this medication, but the problem is that the standards that were used for evaluating the medication were probably inappropriate or not sensitive enough to bring up the differences in response, as our our patient advocate panel, the CEPAC, pointed out. So that's the way I'm viewing the question, that there seems to be evidence that the medication definitely works if you use the proper parameters. The problem is that the studies did not adequately mirror the response of patients in the studies for the therapy.
Okay. Chris.
I just wanted to commend our health economic team for including the modified societal perspective, which is difficult to do. I wanted to just confirm that that included lost time from paid employment for caregivers, which is excellent. Was there also a transportation burden that was included or not included in that? That might be differential between these treatments.
I believe so. I'm not sure on the specifics of transportation, but it was survey-based data of the caregivers, a wide variety of costs, and it included lost productivity, included investment in houses, investment in equipment that wasn't covered, so forth.
Yes, Ed.
So I'm not quite sure where to slot this benefit, and that is that it's a novel mechanism of action that has some compelling biologic plausibility. We don't have enough data to really nail it home, but we do need experience with this new mechanism. I'm not sure that belongs, however, in section 6, or it's a contextual consideration.
I think it's probably best captured in 7, where we have something about it being the first to offer any improvement for patients with a condition.
I wouldn't answer yes to that because it's not the first to offer improvement.
Well, if you're considering the steroids, man.
Right.
Well, we're actually saying, I hear what you're saying, and if you want to capture that, well, I still think it's more likely to go there. But
okay, I could put it under F.
We could, yeah.
You could guide us not to pay attention to first.
Honestly, I think it is best captured under the first treatment. It's just, I think we'll be able to note exactly what we mean by that one. It is both the first, I guess you could say steroids were the first. It's the first of a new mechanism, and that offers a kind of a combination potential benefit. Let's make it a contextual issue. Because it's not like the potential other benefits get somehow extra weight than the contextual issues at the end of the day. It doesn't work that way. Okay, why don't we keep going, because I want to make sure we have time to discuss things when we sum it up for the value for money. Austin and Teresa.
Question. Thank you.
Sure.
So if I'm remembering the cost-effective modeling correctly, one thing that was done was assume 40 years of return to perfect health, yeah? So you can't get any more qualities than that, right? So in that context, I'm having difficulty understanding how, that can't miss anything by definition.
Correct.
Okay, so that's how I'm thinking, that's the context in which I'm thinking about this question. Should be clear what my answers are, how I'm going to respond from that, but maybe others can.
It's a little unfair because that eteplirsen was not the base case model. And in fact, we didn't do a base case model for eteplirsen. So those were, I think, very telling scenario analyses, and I'll just say that. But
that's what I was going to say. I think it's more helpful to send a signal to decision makers that if the model as currently constructed, even if you, as you know, as Suri said, we could have created a best of all worlds, but it's still not measuring these things specifically. It's still something that decision makers in their own consideration around value may want to identify as important issues. So I think it's still worth calling them out here, even if our, if you will, kind of threshold analysis didn't show that it would have made a difference. Teresa.
I'd like to just hear from the clinical experts and maybe even from the patient advocates if there's any steroid-sparing effects when you use the drugs, the new drugs in addition, or are the dosing, is the typical steroid dosing about the same as if you're adding one of the exon skipping or not, which then can obviously have impacts for side effects?
Yeah, I don't think that there is any data to suggest that this will be a steroid sparing, not certainly based on the data so far. In the real life clinical experience, we don't think about it that way. Certainly we don't change the steroid regimen once they go on the exon skipping, they're really combined therapies.
Yeah, I agree. I assess them separately, so I don't automatically reduce the steroid dose when the patients start in Templar session.
Okay.
Okay, let's go ahead and vote, though. I'm going to now label D as the following. I'm going to try to make it short. Just you remember what Lefterio said. He wanted to posit a potential other benefit that there are, I would almost call it a tail of the curve effect, that there is a subpopulation of patients who gain a larger benefit from treatment than can currently be identified, certainly before treatment starts, but that there is a potential other benefit for them over perhaps a majority of patients who get very little, if any, benefit. All right, so go ahead and vote. A, B, C, and or D. Okay, you guys are getting pretty quick at this, so it looks like everybody's done? Good? Okay. 0 for disparities, 4 for reducing caregiver burden, 3 for significant impact on work and productivity, and 8 for Lefterios's other. Okay, that's excellent. And I'm going to assume that the 0, 4, 3s, certainly the 4s and the 3s, are most consistent with Rob's logic, that if you didn't feel that the evidence was there on the clinical effectiveness, that it wouldn't have had these other potential benefits as part of the thinking. If there's something else, I don't think so. But let's go ahead to the contextual issues then. We want to wrap up with the value, long-term value for money votes in just a second. So this one is, again, as you remember these questions, this is about the broader contextual considerations for both of these drugs. Select all that apply. For C, which we talked about earlier, first to offer any improvement. Now, obviously, golodirsen is for a different exon skipping, but just consider them both as the first treatment with a new mechanism of action for this condition, and we'll consider that to be C. So, condition of high severity, high lifetime burden of illness. And now again, remember, conceptually, this is not a comparative question, so if you said before that this was a condition of high severity, it would make sense that you should vote the same here, because it's the same condition. What's changed perhaps are something around uncertainty and other things. Does anybody want to raise another additional contextual consideration before we have any further discussion? Yes, Stephen.
Am I thinking correctly that the lack of good outcome measurements or salient outcome measurements for the population might fit here?
I think it could. I mean, we are going to hammer that nail in multiple parts of the report and the policy recommendations. I think it's not a bad idea to say a contextual consideration around the long-term value for judgment, long-term value for money judgment is that current clinical outcomes data are insufficient themselves to be able to measure patient-important improvements in care or outcomes. Okay, so that is the new F. Yes, Rena, go ahead.
I have a candidate for also F,
Okay.
which is that in cancer, it's common for patients to report that, yes, we know the product that we are facing right now doesn't provide significant benefit, but it provides enough benefit that it gets us to potentially the next thing. which will actually, really will hold out hope in some sense for true value. I haven't really had a sense of that in this setting. Can the patient advocates talk a little bit about that, please?
Sure, Brian.
So I think this goes to a broader issue about marginal benefit. So in Duchenne, moments are precious. And also the benefit that you realize, even if they're marginal cumulatively, they can have profound impact on the individual and the caregiver. So for example, the extension of the ability to ambulate may preclude the necessity for spinal fusion surgery, which may delay the loss of the ability to use the upper body, which may improve pulmonary function. These are all cumulative effects that you may see with marginal benefit. Additionally, there are families who are out there who are playing chess all the time with what is coming down the pipeline with treatment. So yes, in that respect, it's similar to the cancer model in which you describe. But I don't think they're exclusive in nature. I think that people are doing the same thing simultaneously. You're wanting to preserve as much of the moments that you have available to you as possible. My son is, he'll be 25, as I mentioned. He still drives. And anything I can do to allow him to continue having that independence and that quality of life, I will fight tooth and nail to maintain. And like Ron and Minnie have both said, you know, I feel really conflicted about a lot of the economic aspects of this. But having lost a son, wanting to keep my family whole in the present state is basically similar to what these boys want in terms of function. They want to remain whole in their present state. So that's part of the chess that's being played.
Yeah, to answer your question, I appreciate the question. We as a family at diagnosis or shortly thereafter had to make a very difficult decision, and that decision was whether or not to enroll our son in a clinical trial for a drug whose data hadn't been fully published yet, but had been under study for some time. And thankfully, my husband and I are very analytical in nature, and we are easily able to take the emotion out of everything and to try to make decisions based on data and facts. So we actually made the decision to enroll our son in the Sarepta 203 trial for the very reason that you asked the question. We view this as a family decision, that it is getting our son in the best healthy state that he can be for the day that he is living today. And it is a transitionary cost in our perspective to get to the next treatment. And so there was never a question actually in our mind whether or not to give our son eteplirsen under a clinical study trial, because we knew that the opportunity cost of not doing that was far greater than the risk and the cost of actually doing that as a family. You know, we have a serious burden in our family. Duchenne is not a disease specific to our son, and I know a lot of that has been captured through the data, and I appreciate that, but Duchenne is a family disease. It affects our whole entire family. You know, we both work full-time, and to get our son eteplirsen, we are leaving our jobs for half a day every week and juggling our lives to drive 20 minutes away, and thank God it's only 20 minutes away for us, to a hospital setting so that we can have a needle put in our son and give him this drug. We are currently building a home that is ADA accessible and selling our house and moving our entire family. So I love the fact that we are trying to incorporate that burden into this context. I think there's probably a lot that isn't able to be quantified, and I recognize that. So I think there are a plethora of additional contextual considerations. But to answer your specific question, we know this is not the end for our son, but we need this to get to the next. And without this, we can't get to the next. So if we aren't able to continue to access this drug therapy, we aren't able to continue to keep our son in the best situation, and we all know what that natural history is. So we are very passionate about this drug. We have seen firsthand, when I look Duchenne in the face every day, what this drug is doing for our son, and we need this to keep it going.
I was just going to add, I'm really appreciative of the fact that you asked that question, because we are at a time in drug development for Duchenne where the opportunities for clinical trial participation and the number of programs that are ongoing in Duchenne is exploding exponentially. And it's everything from antifibrotics to next generation exon skipping to gene therapy, to anti-inflammatories with, some of the mitigated side effects of glucocorticoids. So, and they're all on the cusp, when you're in clinical trial participation, you have to make, it's a chess match. You're making your choices strategically to be able to get to the point where you have preserved enough function that you can take advantage of something, that's approved down the pike. Now that has implications for pricing, because we know that this is going to be, a combination approach to treating Duchenne. I don't think anybody's saying that, any one treatment is going to be the be-all, end-all. It's going to be a combination of multiple approaches, which has its own implications for pricing structure, which is another frustration that I think we share in the community. But I don't think any treatment out there, has been raised as something that has a possibility of reversing the course of the disease. All of them have been positioned to be treatments that have the ability to, hopefully stop it in its tracks or slow its progression. So that means that preserving as much function as possible is imperative to be able to take advantage of what's coming down the pike. And that the potential of the number of treatments that are currently in the pipeline is extremely promising, which just makes it that much more urgent and compelling to preserve that function.
So what I'm going to do is, economists call that real option value, just as a tagline for it, and it should fit in the potential other benefit pile. So I'm just going to take the prerogative of putting it there and saying that it was discussed and acknowledged as important by all the patient folks, and it'll be an important part of our report. But I'm not going to include it as a contextual consideration, because it does fit more on the other side of that fence. Let's go ahead and vote on these so we can have some time to talk about the long-term value for money votes. So if you can go ahead and vote on all that apply. I'm sorry, what was F? I was now thinking about this for so long. What was? Oh, that's right. That it's an important contextual issue that the outcome measures are inadequate to capture patient-important improvements that could be provided by treatment. These treatments so far. All right, so that's F. All that apply, and then look up at me. Okay, everybody done? All right. 16, severity. 15, lifetime burden. 10, first with a new mechanism of action. And again, this is, we'll keep going. 8 is the significant uncertainty about long-term risks and side effects. 11, uncertainty about the long-term duration of benefits. And 16 out of 17, the contextual consideration around the inadequacy of outcome measures. Okay. So the purpose of that somewhat torturous process was to expand our thinking, to make sure that we were open to other aspects of value that are important to patients and families, to the system. And now we're going to return back to pulling it together on a vote on long-term value for money. Now, just a little bit more about the terminology again. I mentioned this at the very beginning. Value is a tricky word, because to a patient, to a family, value is intrinsic in the benefits that they can get, or even the hope that they can get from a new treatment. That has value. Our term value for money is meant to think about that as part of a bigger spectrum of including the evidence on comparative clinical effectiveness, the cost effectiveness. So this really does put it in a, if you will, in a context of thinking about the value for the money. So votes here are not intended to say that patients aren't important, or that having treatments and access to future treatments isn't important. None of that. This is a, if you will, a hard-edged look at the value for money, which can mean that an extraordinarily successful and, great quantitative leap for mankind kind of treatment can still be overpriced or not. So it's all about that context that we try to bring here. So the votes are categorized as either low long-term value for money, intermediate long-term value for money, and high long-term value for money. Because we've talked about the clinical effectiveness and these potential other benefits in context, I am going to return to Suri just to quickly summarize the incremental cost-effectiveness results, because the first question is about deflazacort versus prednisone.
So again, I think our model should be viewed as a quantitative lower bound to the ICER, given the available evidence in terms of quality-adjusted life years and life years gained. And then our base case model, we found cost per quality gain of $344,000 from the healthcare perspective, and from the societal perspective, $371,000 per quality-adjusted life year.
Okay, and just to make sure that the vectors are headed in the right way, a lower bound on the incremental cost-effectiveness ratio means it's the best case for this drug.
That's right. And again, that was primarily reflected in this 3-year loss to ambulation, which was found in one study. It was the highest effect measure that exists in the literature.
Right, so taking that as the assumption, the ICERs were in the 300s. Okay. Did you guys have any questions to circle back on as far as the cost-effectiveness analysis? Again, we had a pretty good chance to talk about some of that. Here again, if there are any other thoughts that you have about how to integrate some of the other aspects of the information around comparative clinical effectiveness or the potential other benefits, if you want to sway your colleagues around how you think you're going to vote and you want to hear them express that out loud, does anybody think they're going to vote unlike everybody else? I would like to say why. No black sheep? Okay. It's been a very rich discussion. Why don't we go ahead and vote on the long-term value for money of deflazacort versus prednisone? Low value is A, intermediate is B, and high value is C, value for money. Okay, here we go. 14 are low long-term value for money, 3 are intermediate. All right? In 1 minute, would somebody who was an intermediate value care to express their rationale behind their vote? Don't have to, but yes, Lefterios.
I can take this one. I felt that the weight difference was not captured in all its effects. I felt that it's borderline. I think that I was between low and intermediate, but I felt that with the study still ongoing, I felt that most likely, since it's already in the lower end of cost-effective, the way that we define it here, I felt that intermediate is the appropriate vote for me.
Okay. We'll note that in the record. Anybody else want to add a comment around their intermediate or low vote? Okay, let's go to the last voting question. Given the available evidence on comparative effectiveness, incremental cost effectiveness, and considering these other benefits, disadvantages, potential other benefits and disadvantages, and the broader contextual considerations, what is the long-term value for money of treatment with eteplirsen versus supportive care with corticosteroids alone? Just to note here, we're not going to take a vote on golodirsen because it doesn't have a price. So we don't have, if you will, the findings of a cost-effectiveness analysis. Suri, I think we've talked about this a fair amount, but just, again, briefly, the basic findings.
Yeah, so basically because the cost of the drug is $1 million per year and you have to take it every year that you're on the drug, that kind of precludes it from having a low incremental cost effectiveness ratio by any measure. In our model, the context of our model, even with very large shifts such as 40-year shifts, we find extremely high incremental cost effectiveness ratios, over $1 million per quality, close to $2 million per quality. And even if you take patients and presume they return to perfect health and live a full life, it's still a very high incremental cost effectiveness ratio.
Okay. Any of the patient advocates want to have one last bite at this apple before the vote? We've already talked a fair amount about it, but you're welcome to have a comment.
I think this is an extremely uncomfortable position to put us in. I don't think that's, I mean, how am I supposed to comment on, the value of my son's life and make some sort of statement on how it offsets, his cost impact on the healthcare system. I think it's inappropriate to ask us to comment on that, to be honest with you.
Well, to be honest, that's why we don't have you vote. We don't feel that that's fair, certainly. Comments are fine. All right, Ed, yes.
I really liked having the cure model to consider. I mean, I don't think it was for the drug itself, but for maybe another drug that's going to come along down the line that's going to essentially give us a cure. And the model for a cure probably doesn't reach a level of cost effectiveness that's tolerable.
Yeah. Oh, okay, Jean, yes, please.
I think we're all in a really uncomfortable position. I don't think we share the same level of pain and concern, and I don't want to pretend that we do. But I'm going to need to walk with Reverend Al after this session, because this is a really morally precarious place our country is in at the moment, to have to make decisions like this. For providers to have to make these decisions, for families, and for those of us who are supposed to watch out for some kind of public trust. So.
I mean, I guess I will say that the premise that you have to save as much money as you spend, is a very small calculus, and I think that it doesn't take into account, a lot of the value perception that those of us in the community have, in incremental changes to quality of life of our loved ones. So, on its, I mean, there's judgments being asked to be made here that I think are far beyond just pluses and minuses in terms of how much burden someone is on a healthcare system and how much benefit they incur from treatment.
I guess I would respond that I don't think we're taking that approach. As Stephen pointed out at the beginning, this is not a zero-sum game. And we're not talking, at least I know I'm not, and I know a lot of these people well enough to know, we're not thinking about this as people burdening the system. I don't think that's the approach at all. And I hope you don't feel that way after sitting with us in this kind of discussion. That's not where we're coming from.
Yeah, I completely agree, but let's continue. Yes, please.
I asked my son recently how he thought the drug was working with him, and he told me that he had stabilization. He's been on drugs for 2.5 years, and we've seen very little change in function. And I would say attenuation, but I'm a little more pragmatic, I suppose. And for me, irrespective of the terminology, that's priceless. But it really isn't, because we don't have to hire caregivers. He can drive. If the places he is going to are accessible, then he's able to go independently. If he's not on any ventilatory support at this point, that's not another machine that's in our home, in our medical setting, in his bedroom. My wife and I are able to do things independent of my son without having to bring somebody else into the home. We can actually leave him alone and are comfortable that he can get out in case of an emergency. He's able to communicate with a network of friends that he has developed. He's able to travel. These are all things that are afforded to him that his brother lost at age 16. Those, it may be intangible to some people, but in our world, they really have significant value. So that, I guess, would be the way that I would answer that statement about the contextual consideration.
Yeah, thank you. So it's, oh, please, yes,
Sorry,
no, go ahead.
I don't mean to monopolize the conversation, but there are two questions that are under consideration here today. And one of them is, whether these treatments kind of alter the disease trajectory for our individual children. And the other question is the amount of change in that disease trajectory, of value, taking into consideration the amount that's being charged for that. And I think, those of us here whose children have been treated with some of these compounds are pretty confident in our ability to speak to the first question. The second question is a really frustrating one, because we have no control over the pricing structure, and we have frustrations with it as well. And so I think when those two questions get conflated into one, I think that's where the frustration comes from on our parts.
Thank you for pointing out. I think you're absolutely right, and I wanted to just accentuate again. That's why it is hard to put everybody, but especially patients, in terms of value for money. The value piece is what's intrinsic to what you're seeing today with your kids, and also what you hope for is on the horizon. And so putting it in the context of value for money itself feels awkward to some extent for many folks. But as we are going to pivot to talk about coverage and pricing and future research, it's also with a view towards the big system in which we're all a part, where we're trying to find a balance. It's not a zero-sum game. You can be highly cost-effective, as CAR-T was, at $500,000 for a treatment, $2.1 million for a gene therapy for kids with another neurologic disorder. But at some point, there's always a downside as healthcare costs grow, and that means some people won't be able to afford any insurance. It means that we may not be using our money in the best way possible. So we're going to return to that as part of the policy roundtable. But I'm really glad we had a chance to get that out on the table and talk about it some more. Are there any more comments or questions before we take this vote? Okay, please go ahead then for eteplirsen versus supportive care and corticosteroids alone. Long-term value for money. A is low, B is intermediate, and C is high. Okay. 16 low and 1 intermediate. Martha, are you the one again? Or no, I'm kidding. If anybody would like to discuss their 1 intermediate vote, they're welcome to. Albert?
Actually just listening, to the patient advocates, Pete and Brian, you really touched my heart. But that being said, the comment that you made about the fact that for 2 years, your son has been able to function, how do you put a price to that? So that's what I was struggling with. I really didn't even want to respond to this particular question because I was so perplexed about it. But I just see it having it does have value. And, that's it. That's my reason behind that. But, you were the inspiration behind that.
All right, thanks. Austin, please.
Well, I just want to add, I feel identical to him, that there's absolutely value. But clearly I didn't vote for intermediate. So we share the same feeling, but that feeling is different from the question that's asked, to me.
Do you want to say more, or is that?
There's a broader context. When resources are finite, unfortunately, $1 million spent here is $1 million not spent elsewhere, and that's what we're wrestling with. I mean, that is precisely what we are wrestling with, and we are asked to wrestle with that seriously. That is very hard, and it does not discount the value of every single treatment to every single patient and family who receives it and perceives benefit. Those are different, and I mean, I'm emotional about it too, but I voted differently for that reason.
Okay, let's move on.
Yeah, and I would just say, it was right for you to ask if it was me who was the singular vote, but I feel different about the effectiveness issue than I do about what I think is an extraordinarily expensive issue that we're going to be talking about, I guess, now. Things need to be affordable for people in this country at the individual level, and they have to be affordable at the population level. And there are lots of things that we give up now because we spend so much money in the medical care arena that we don't have enough money for social services, for education, for transportation. So that, I think, goes back to what you're talking about. We're sort of trying to balance those things.
Right. Okay, I tell you what, let's take a break and come back because this will be part of our discussion in the policy roundtable. It will underpin a lot of that discussion. We'll talk about future research. We'll talk about coverage, pricing, and what we can do to improve the world for patients and others. So we'll come back at 2:30 to start back with the policy roundtable. Thank you.